Welcome to Shielded, the podcast dedicated to helping Florida's first responders understand the laws that affect their work and their lives. We bring clear answers, practical tips, and stories to help you when you need it most. If you're a first responder in Florida, this is your playbook. Be sure to check out all of our resources at bicklerlaw.com. I'm your host, Paolo Longo, and I'm here with my partner, Jeff Bickler. At Bickler & Longo, this is what we do. Now let's get into it. All right. Hello, everybody, and welcome back to Shielded. Today, we have a special guest. We are joined by Dr. Stephen Borzak. He is a highly respected and board-certified cardiologist with more than 3 decades of experience diagnosing, treating complex heart conditions as a cardiologist. He's recognized in his expertise in dealing with arrhythmias, cardiac impairments, cardiovascular risk, especially in high-stress occupations, including the challenges faced by firefighters, law enforcement, and other first responders. Over the course of his career, he served in several leadership roles in cardiovascular medicine. He's published peer-reviewed research. He's participated in studies involving arrhythmias and heart failures, ischemic heart disease, and even occupational cardiac stress. His work emphasizes evidence-based care, careful functional assessments, and basically a real comprehensive understanding about how these medical conditions translate into real-world limitations. He's not known just for his medical experience, but for his clear and practical advice and communication style, taking these really complex issues and explaining them in ways that make us understand this stuff a lot better. We're honored to have him here today with us to talk about cardiovascular problems that our clients suffer, including heart disease, arrhythmias, disability, and all the various protections that are available to first responders under the Heart Bill. And I would be remiss if I didn't say he's not just a great doctor, but he's a heck of a guy too. So Dr. Borzak, thank you for joining us. And how about that for an intro?
Well, it's an unrecognizable intro, but hope to not disappoint. And it's my pleasure to be here. Thank you for inviting me.
Well, it's our pleasure. So you're beginning the doctor series, we're going to call it, and talking about Heart Bill and what it is. So let's kick off, I guess, with talking about, what is heart disease and what are the kinds of things that you're looking for when you're asked, is this heart disease?
The first thing we look for are symptoms, see if anyone has any symptoms, and then we look for physical findings, and then we look at laboratory studies. Much as it's interesting as a cardiologist to deal with some complex, very difficult to manage and unique situation, I have to say that my passion is really with prevention and dealing with a lot of first responder cases where I see firefighters and police officers get into trouble, having events, and then dealing with the aftermath. It'd be much better to stay out of trouble rather than to get out of it once you're in it. And
well, right. But the problem is by the time they get to you, they're already in trouble, right? So prevention becomes a little more difficult. Right?
Absolutely. And I guess if everyone was prevented, that would put all of us out of business. At least you guys, maybe not me, but.
Well, let me say, doctor, I've joked many times. I wish, that we had a better way of approaching these cases so that you could put me out of business happily, to be honest, if we didn't have to deal with so much of the tragedy that we deal with, not only with respect to heart disease cases, but, cancer claims now with firefighters and PTSD, suicide claims and all of that type of thing that we deal with all the time. So I think we're very much in alignment with you on the idea of prevention and early intervention from the outset, regardless of the type of condition that we're working with. So, there's a bit of I think, a misnomer out there with respect to the work that we do. We really are trying to be as proactive as we can in assisting these communities to get the medical care they need early so that they don't end up disabled and losing their career. So I really do appreciate you saying.
One of the things that's interesting when I review a case for a claimant or a defense is to see the whole professional career of someone telescoped into about 2 hours at my computer, from the pre-employment physical all the way through the years of service, and watching the medical details evolve over many years, but telescoped into a relatively short time for me when I'm reviewing and writing the report. And so it really drives home the point that there are many opportunities along the way to be aggressive with prevention And many of the consequences of risk factors can be manifest very late, but have an opportunity for early intervention. And that includes healthy lifestyle, blood pressure management, and in particular, cholesterol management. Nobody who's young and healthy and working very hard and serving the public wants to feel like a patient or wants to feel like they need to be taking medicines. And there's a natural resistance to doing so. But sometimes lifestyle management just doesn't work to control risk factors. And I would encourage all of your listeners to not feel that taking a pill is a defeat or giving in to something or in some way diminishes them, but it's really an opportunity to not be missed
Sure.
for getting in early. And it's kind of like starting your 401k with your first job, as opposed to waiting until you feel like you've got something to put away in the bank. You want to start
You know,
early and work
I think,
aggressively.
and I think that's such a valid point, especially since I know we wanted to talk to you about disability and this whole game that we play in this practice, and with respect to the Florida law about covering a condition only at the point of disability. I mean, I've always maintained that from a public policy perspective, it makes no sense to wait until somebody is disabled to begin treating a condition, right? And I think that's partially what you're saying here. When you look at a case and you look at 25 or 30 years of medical records from a pre-employment physical, and you can see various stages along the way where there might have been intervention. Yet this goes on until somebody becomes ultimately disabled due to a condition. And it really is sort of backwards in terms of how I'm sure you would like to approach things as a doctor. And from our perspective as well, again, it gets back to this idea of early intervention and disability. So why don't we talk a little bit about that? Because I know that that's such a hot issue and something that you have to deal with so frequently, when you're testifying in these cases. What are your thoughts about the disability problem in Florida?
No question, prevention is much better than dealing with the consequences of the disease once it's manifest or fairly far advanced. I can't speak to the legal aspects of workers' comp, but it is awkward that the system that was designed to deal with an on-the-job injury is now being applied to medical claims. And it's awkward. We all feel that it's trying to drive a square peg into a round hole. And it's not like you can treat hypertension or coronary disease or arrhythmias by setting a bone or performing an operation and then sending someone right back to work. These are chronic medical conditions that aren't suited to the way the system was originally designed. It's not to say it's not workable, but it's to say that we have to reimagine, rethink, and perhaps modify some of the rules and some of the rules of engagement a bit in order to make it fit better.
Well, yeah, and I guess that's really what I was suggesting, because for me, and this goes back to the very early part of my practice when I was representing firefighters in Dade County. I was working at a practice down there. And the county at that time, and this was back dating myself, it was in the 90s, the early 90s when I started practicing. They didn't require anybody to establish disability to cover a hypertension condition. And they simply accepted it. Once you were diagnosed, they accepted the condition as a matter, again, of public policy and sort of following what the heart bill was, and acknowledged the claim and then paid it. And so it allowed for early intervention, and really getting on top of these cases in the earliest stages. Pressed, and as employers saw opportunities to deny claims, they started getting a hold of this notion or idea, and that disability was required in order to establish an occupational disease claim. That has sort of evolved now into what the state of the law is. So that's, again, getting back to what the public policy I think should be, which is, look, if you're going to cover heart disease, and I understand what you're saying, doctor, because I've had this discussion with many cardiologists over the years, right? It's like, well, this doesn't really seem to fit in workers' comp. But we made a decision in Florida as a matter of public policy that the first responders would be covered for heart disease and hypertension. So, once you make that decision, then you've got to figure out the best way to utilize the law. And it seems to me that disability is just one of the problems that we have to contend with frequently. And, I appreciate that, you're sort of punting the issue, and that, this is really a legal issue and not a medical issue. But you've got to contend with,
It,
right?
it would be a game changer if disability were not required for these conditions to be covered under comp. No question about it.
Right. Well, at the end of the day, money talks, right? So those cases that Jeff was representing in the early 90s, when, 20 years later, they're still paying these claims, and somebody starts looking at the amount of cost of the medicine and then the surgeries and, medical care and exams. And they're like, well, who picked up this claim 25 years ago? And, when they weren't quote unquote disabled, the carriers start pinching pennies, and they start really hammering us on all the elements. And so, speaking of disability, what does that look like, in your mind, right? When you're being asked either by a claimant lawyer or the defense lawyer or the employer, was this person disabled? What is your process in that? And then how do you determine when it's safe to send somebody back to work after one of these events?
The question of disability is a bit of a legal and a bit of a medical issue, and it's fairly simply defined as not being able to work and not being able to perform your job functions. And for some situations, it's very easy to determine if you're under anesthesia or having a procedure or hospitalized or in the emergency department. It's fairly clear. There are some guidelines that are somewhat helpful, but don't usually deal with acute situations. Some people are familiar with the ACOEM guidelines for police officers and law enforcement officers and the NFPA guidelines for firefighters, but they don't really address the situation that we're talking about, which is in an emergency department or in an office visit under a specific and acute circumstance. Plus, they're guidelines. They're not really definitions. Just like the guide is a guide for examiners, it's not a legal code, even though sometimes legal principles are applied to it. It's a guide for me to help provide an assessment and an impairment rating, and not so much legislative language.
Right, but it's interesting that you bring up the guide. So you use the NFPA and the police guides and stuff. You use those guides when you're looking and evaluating these claims?
I do. The ACOEM guidelines are much more strict and in much greater detail than the ACOEM guidelines for law enforcement officers. But even then, they're just guidelines. And we can sometimes look at an individual and make a determination that's a bit outside the guidelines, provided there's enough support, both medically and in terms of family support.
Right. And earlier we were talking about risk factors, and I'd like to spend a couple of more minutes, talking about that. We talked a little bit about modification of risk factors, but when you're dealing with workers' comp, and we're always faced with, cause, right? And I'm sure in all the years in training and medical school and residency and all the other stuff, there's no causation class in medical school, right? You're not learning always about what causes something. You're learning how to treat it and fix it and make it better, right? So when you get to causation, how do you sort of justify or fit those puzzle pieces together when somebody's asking you, what caused this heart attack, or what caused the need for this pacemaker or something like that?
We learn a lot about cause in some ways, but that's from a medical perspective and not a legal perspective, and they're very different. In its simplest, you take an infection where there's a specific bug, a specific germ or bacteria, and it can cause an infection. That's in its purest form, easy to determine the cause. But then you get into the issue of, well, how did you get the bug? And was it person-to-person spread? And how far apart do you have to be? And all of those are nuanced questions that really come more from experience and less from laboratory science. But applying legal principles to a clinical scenario is something that is not taught, but it's something that we learn en route as we come to understand the questions that are being asked and the legal principles as they apply to medicine. I sometimes think of you guys as knowing enough to be dangerous in the exam room. I kind of know enough to be dangerous in the courtroom too, but hopefully we stay in our lane and respect the boundaries.
Yeah. I try not to flex my Google medical degree too much.
Dr. Longo, Dr. Longo.
Hey,
Yeah, I mean, it's so interesting because, and I know that a big part of the study of cardiology, of course, involves all the risk factors and what do you do with the risk factors to minimize the risk, right? So we all recognize the multitude of potential risk factors that can affect cardiac function, but when we're trying to deal with this from a legal perspective, and that I think that's what's so interesting, really, about handling heart claims in Florida is how the burden of proof shifts to the employer to show a non-occupational cause of a condition, and we had a number of cases over the years where the court weighed in. I think you're probably familiar, doctor, with the Punske decision, where the court said that a constellation of risk factors could qualify as non-occupational cause. And that kind of idea, I think, is slowly unraveled over time and through the course of litigation. But I'm just interested to hear what you have to say about that and trying to define, say, a non-occupational cause, where you've got a multitude of risk factors.
Really illustrates the point I was attempting to make before, which is that we know that hypertension can lead to heart disease, heart failure, and coronary artery disease, principles that came from the investment in the Framingham study that we've all heard of. But that doesn't really say, did this particular guy's heart attack come from his hypertension? And for that, I think we need a more in-depth understanding of the extent to which there's a dose and a response. For example, someone who just started a blood pressure medicine 3 weeks ago because their pressure was 141/91 is a lot different than someone who's been on 4 drugs for 30 years for hypertension and has been poorly controlled. And that's something that goes beyond the dichotomous understanding, hypertension, yes or no. Someone whose diabetes has been long-standing since childhood, on insulin, poorly controlled, with all sorts of manifestations of diabetic end organ damage, that's a lot different than someone who started metformin last week because their glucose was a little high and they need to lose 10 pounds. So these risk factors are extremely important and are causative, but to understand for a given individual, do they reach the level of producing more likely than not a cause, requires some understanding and some weighing of the strength of each of these risk factors in a given individual. I'll give you another example. Sometimes we encounter people who have a diagnosis of heterozygous familial hypercholesterolemia. That's someone who not only has a high cholesterol, but really has a super high cholesterol that's 2 or 3 standard deviations beyond the already elevated average level in North America or in the United States. And recognizing that diagnosis is a lot different than someone who just started a little bit of Lipitor or atorvastatin because, maybe their LDL was a little bit high. Those are important factors that weigh in on understanding cause.
Well, and kind of like sort of tagging along to what Jeff said, there's how do you distinguish between occupational and non-occupational when you're dealing with a population of first responders who are exposed to things that you and I, as lay people, aren't, like shift work, adrenal response, exposure to toxins, chronic stress, those kinds of things. How do those things in your mind play into effect or work together with regular risk factors that the rest of us have?
Those unquestionably are very important. And although some of our risk factors are measurable, for example, we can measure a blood pressure, we can measure a glucose, we can measure a hemoglobin A1C or a cholesterol level. That's a pseudo measurement because it doesn't really tell us how much does that risk factor contribute to the illness that the individual has. Stress is very difficult to measure and to quantify, yet everybody knows that being a first responder is stressful, whether it's being in a truck and getting ready to run into a fire, or facing a bad guy, or breaking up a fight, or dealing with marital discord, or working in a prison. Those are unquestionably stressful situations, and it perhaps is the understanding of the legislature that gave us the presumption so that we don't really have to try and weigh those in a medical sense, that it recognizes, that the legislature recognizes that being a first responder is a very difficult and demanding job and can contribute to these stress-related conditions like high blood pressure and heart disease.
I think that's a really important point, Doctor. I really do feel that that's what is sort of undergirds the whole move anyway to bring the first responders under this protection. And it goes back a long ways for the firefighters, more recently for the law enforcement corrections officers. But I think that is ultimately the heart of why the legislature intervened and created this.
Right, and imagine the guy who invents the stressometer so we can measure the stress, right? I mean, he'll retire soon, right? So go back to the risk factors and causation, right? You were involved with a case that we had, and I guess this is going back 10 years or so ago, where the word trigger came up, right? And what was the trigger? If we can't identify the cause of the disease, can we, in certain circumstances, identify the trigger, which was the need that whatever began the necessity for the care? How do you sort of split that hair?
Perhaps I could provide some of the details of that case and to help illustrate your question or my answer to your question, Paulo. The case involved a firefighter who had a slow pathway. This is an electrical abnormality in the heart that a lot of people have. It means it's like an accessory connection between the top and the bottom chamber, and under the right circumstances, it allows for the electrical impulse to race around the AV node. It's called AV node reentrant tachycardia, and it produces a supraventricular tachycardia, very fast heart rate. So in order to have this type of arrhythmia, you have to have the slow pathway. But a lot of people are walking around with the slow pathway and they don't have it. And our case involved a firefighter who was in a burning building wearing 80 pounds of gear and came out because he felt his heart was racing and he just couldn't calm down. And sure enough, when his buddies hooked him up, he had AV node reentrant tachycardia going around 180 beats per minute and went on to get it treated. We have an ablation procedure that works pretty well for this. He had the ablation and he was cured of the illness. So on the one hand, you could say, well, he had this congenital problem. That's definitely not occupation related. But the way we looked at this was that that really serves as the substrate. That's the condition that allows for the tachycardia to occur. But then he had a trigger, and the trigger was the intense surge in his stress hormones that occurs when anybody's running into a burning building and wearing 80 pounds of equipment and breathing through a mask and looking for victims and so on. So it was the combination of the substrate that he was born with and the trigger that was clearly occupation related that produced the situation that was recognized by the court as being a compensable claim.
Right. Yeah, that one
And
went,
that,
I think, through the appellate courts.
yeah, and that turned out to be an extremely important case because it really did change to some degree the analysis of a lot of these claims. Where we sometimes have an issue with respect to causation, then there's always the question as to the trigger now, and that's a relatively new development based on that recent decision in the case that you were involved with, Dr. Borzak.
Yeah, and so let's take a few minutes and talk about prevention. I know that's important to you, Dr. Borzak, but when you're talking about prevention, I mean, that's a big umbrella, right? That's a big area that we've got to talk about. So how do you tell first responders to prevent heart disease when their job has been recognized legally to cause heart disease?
We go back to the concept of the risk factors. You can't change someone's job, and changing their job description, I guess, is a different matter. But we want to make sure that the conditions that they go into their job first thing in the morning or at the start of their shift keep them prepared and optimized for the circumstances that they'll encounter during the day. And that means they should have well-controlled blood pressure. They should have their cardiac risk factors modified as much as possible. Sometimes it is a lifestyle matter. People can be on diets and many are exercising. Obviously, smoking is a huge issue. Not many people are smoking so much these days, but that's the most toxic of all the risk factors. One cigarette alone could account for stacks and stacks of cheeseburgers if you wanted to try and put them on a scale somehow and balance them out.
Right.
So smoking is a tremendous investment if someone is smoking and needs to quit smoking. I spend a lot of time in the exam room talking about it, which surprises a lot of patients because, you're the cardiologist. What are you talking about smoking for? And that's because it's the biggest bang for the buck. I can produce the greatest benefit even without drugs by getting someone to quit smoking. A lot of people are reluctant to take medications, and I understand that. I'm not in the business to support drug companies, but sometimes medications work a lot better. We had a lot of lifestyle studies that were done in the 1970s and the 1980s, putting people on different diets to see if we could prevent heart disease. We had the concept of a low-fat diet that didn't really work out. We had the concept of a paleo diet or an Atkins diet, which is appealing to a lot of our mutual patients and clients. But the problem is that none of those strategies really worked very well, just from a practical standpoint. Sometimes they led to weight loss, which is contributory to risk factors, but they just didn't reduce coronary disease death or the coronary disease incidence very well. And what the biggest game changer in my career was a study that was presented and published in 1994. It was called the 4S study, and it stands for the Scandinavian Simvastatin Survival Study. This was the very first trial with cholesterol-lowering drugs using a statin. Up until that time, we had lousy drugs that were poorly tolerated, that lowered triglycerides or didn't do much for the LDL, which turns out to be the key factor in producing coronary disease. And this study using simvastatin in 4,400 patients showed a 30% mortality reduction, which was incredibly stunning and was a paradigm shift in the whole field. And that shift has remained to this day. Every single study that's been done, either with statins or with other drugs that lower LDL cholesterol, has fit the curve and has done exactly the same thing, which is the more you lower LDL, the more you lower coronary disease risk, and not only prevent coronary death, but also heart attacks, strokes, angioplasty, bypass surgery. It works in men, it works in women, it works in high-risk people, it works in low-risk people. It's a tremendous investment. Nevertheless, statins have a bad reputation in the internet and in the Google search engine. They're the safest and the
Side effects,
drugs that I use. Sorry?
because of side effects primarily. Is that the
Well,
concern?
yeah, nobody wants side effects, but I've had people decline statin prescriptions because of side effects. And I said, dude, you can't have a side effect if you don't swallow the pill, at least give it a try. And if you have a side effect, don't take it. I don't want you to be miserable. It doesn't make sense to be miserable to live longer and miserably. But the drugs work very well. The side effect profile, while it's not zero, there are no serious or long-term side effects, and they stop if you stop the drug. We do have alternates, but that's a great place to start. It's a tremendous value and investment that I think people should embrace. Sometimes people want to negotiate the dose with me. My response would be, listen, if you knew how good this was, you'd ask for 80 and not 40 milligrams instead of trying to get me down to 10 or 5 milligrams.
Isn't that funny? How do you feel about the GLP-1 agonist and the weight as a weight loss tool? I mean, how do you feel about that as a
Yeah.
cardiologist?
Yeah. So, weight is a common factor. It's not the be all and end all, because someone who's fat and fit may have a lower risk than we would otherwise think, but it's still central, because if weight loss is achieved, blood pressure usually comes down, at least to some extent. Sleep apnea, which is a factor, often improves. Glucose gets better, and cholesterol can come down a little bit. Sometimes to the point where some of the medicines, but usually not all of them, can be stopped. GLP-1 agonists are this new class of drug, Wegovy and Ozempic, all the drugs in that family. And they're proving to be really, really effective at achieving weight loss and glucose control. They also appear to be safe and possibly even beneficial in preventing heart disease. Not so much so that we've started using them in non-obese individuals, but their track record is pretty amazing, and they're safe and they work very well. Again, not everyone is going to have a side effect-free existence on these medicines, but they're excellent, especially if weight control is a challenge for some of our patients. And I do see this when I look at the 25-year perspective. The pre-employment physical, 170 pounds, and by the time they're towards the end of their career, sometimes it's in the high twos, unfortunately.
Yeah, 300 pounds. Have you started prescribing those medications, doctor, to any of your clients?
I kind of have my hands full getting authorizations for the cholesterol drugs and for the heart failure drugs. And so leaning into the GLP-1 agonists, which often come with their own authorization processes, have been challenging. I haven't done much
Let
prescribing.
us help you with that. You have clients that need that medication. You let
Not,
us
not
help
because
you.
it's not valuable, just because there's only so many hours in the day, but I do recognize the value.
Right. And I'll bet you the studies, that come out in the next couple of years are going to show that it's lowering, cases of metabolic syndrome and things like that, which are, right, doesn't all that contribute to the development of coronary artery disease anyway?
Definitely.
Overweight and high cholesterol and high blood pressure, if you can lower the trifecta, then you're obviously increasing your chance of living longer and reducing development of heart disease.
Definitely.
And what about how does all those risk factors and the meds, I mean, we spent a lot of time talking about heart disease, this sort of coronary part of it, but what about the arrhythmia part? That's a whole nother sort of bag of worms that we're dealing with
Yes.
the arrhythmia section.
Yes. The heart has its own set of electrical issues as well. Some of those are related to some of the risk factors. For example, atrial fibrillation is linked to obesity, and some recent data has suggested that weight loss can be an important way to reduce the frequency, duration, and severity of atrial fibrillation episodes. So that's an important strategy that we employ. But the electrical abnormalities are fairly common in our population and sometimes require drug treatment. Sometimes they require electrical treatment, intervention. We have ablation procedures which have progressed and have gotten better and better all the time. and that poses a set of separate problems. They can exist in their own right in the absence of any structural heart disease or other risk factors, and sometimes they go together with other types of heart disease like heart failure.
Well, isn't that interesting, doctor? I mean, the case that we had come out a few years ago, the Harlem case, which created so much confusion, really was trying to suggest that cardiac arrhythmia conditions were not even a form of heart disease that the legislature intended. So I'm sure you've testified a number of times related to that particular issue, but just for the record, can you clarify that is indeed heart disease?
Yes, well, I think those of us who are cardiologists in this field were stunned when we read the Harlem case and the judge panel concluded that electrical abnormalities were not heart disease.
Unbelievable.
I'm like your general contractor, Jeff. I get the electrician, I get the plumber,
Right.
I get whatever subspecialists you need to keep the house in shape and keep the old model running, I guess.
Well, it was if it makes any difference, or it was as stunning to us as it was to you when that decision was issued. So I think we're all on the same page there. And believe it or not, I mean, those cases continue to be litigated. I think until we get further direction from the First District Court of Appeals, we're going to continue to see those cases go into trial. So
Yeah, and I can't tell you how many conversations I've had over the years, Dr. Borzak, where I'll talk to somebody after coming home from the hospital, and I'll say, "Well, how long have you had this problem?" And then they say, "Well, my doctor put me on this medicine, like 5 years ago. But I lost a few pounds, and I started walking after dinner, and I got my blood pressure a little bit better, so I quit taking the medication. And then here we are. I'm talking to him, after he's got a stent or worse."
Yeah. Well, it is nice to stop a medicine because you no longer need it, but that's kind of a shared decision and it's not always a great idea. Your blood pressure can only be so low. And if it's too low, you get dizzy, you get lightheaded, and you can't function. That's pretty simple and easy to understand. But you can never have too low of an LDL cholesterol. And in fact, our studies have shown that the groups in these large trials that have the lowest event rates are the ones that have the lowest achieved LDL cholesterols. So sometimes there's a mistaken impression that the goal is to be on as few pills as possible. And I usually have to inform our patients that they've lost the contest already. There are people who will die with never having taken a medicine, but we don't know at what age. And listen, you need to do this. This is something that's going to help you. It's beneficial. And if it becomes no longer beneficial, then you don't have to take it. Nobody is being asked to sign a lifetime contract to be on drugs. That's another fear that people have. I'll have to be on it for the rest of my life. And sometimes my response is, I hope that's a very long time.
Right. Well, with all due respect to my doctor friends, every doctor's going to say, quit smoking, lose weight, low salt,
exercise.
exercise, right? But
Everybody knows that, but it's also hard, and it's human nature. And if we could all control those things to the optimum degree, then we would need far fewer medicines. But it's
but specifically to this population of people, right? Police, fire, corrections, our first responders that are doing this thing. Is there anything that you would say? I mean, if you could give a first responder one golden nugget of heart health advice, what would that be?
invest early. Invest early in your prevention program. Don't wait until the cat's out of the bag or the engine is out of the barn.
Because
Invest early.
statistically, that population of people runs into higher incidence of heart disease, be it plumbing or electrical, than your average Joe.
Yes. Yes, we
Get
recognize that, and that's why the presumption exists. So invest early. Lean into the prevention strategies and don't fight them if they're gonna help you.
Sounds like you need wellness programs in all the agencies in the state, right? Where we've got these guys paying more attention to their physical health in a way that could be preventative with respect to cardiac disease. I certainly
Yeah,
agree. I
it's not
certainly that assessment.
the prevention isn't always being yelled at by your doctor or by your wife and it's not always taking a handful of pills, but it can be some combination and it can be tailored and it can be side effect free and inexpensive, but invest early and stick with the program.
right, and certainly prevention is a heck of a lot cheaper than post bypass, right?
For sure.
All right. Well, we appreciate your time, Dr. Borzak. Thank you so much for giving us some of your valuable time and for your insights. It's a pleasure working with you and talking to you. So again, thank you for your time.
It's been
Always a pleasure, doctor. Great seeing you again. Thank you.
Likewise. Thank you so much.
Thanks for listening to Shielded. At Bickler & Longo, this is what we do. We've represented thousands of first responders across the state of Florida. If you need assistance, don't wait. Please reach out. To learn more, head over to bicklerlaw.com or email us at info@bicklerlaw.com. You can also follow us on Facebook and Instagram at Bickler Law. And if you found today's episode to be helpful, please share it with a fellow first responder who might need to hear it. Until next time, stay safe and thank you for all you do.